Bismillahirrahmanirrahim. Dear students, today we are going to discuss one of the very important topic, which is myeloproliferative disorders. I am Dr Adrees Shani, working as Assistant Professor of Medicine in Medical University, Faisalabad Medical University. Dear students, basically myeloproliferative disorders, there are two types of disorders. One is the classic disorders and second is the atypical disorders. So among the classic disorders, there are two varieties. One variety is Philadelphia chromosome positive, which includes chronic myeloid leukemia. The second category is Philadelphia chromosome negative. That includes Polycythemia rubra VERA, essential thrombocythemia, chronic idiopathic myelofibrosis. So we will be discussing in the next slide Polycythemia rubra VERA and then essential thrombocythemia. In the another lecture we will discuss the chronic myeloid leukemia. Atypical disorders among the myeloproliferative disorders include chronic neutrophilic leukemia, eosinophilic leukemia and mast cell leukemia. Dear students, Polycythemia rubra VERA is a chronic stem disorder in which excessive proliferation of the erythroid, myeloid and megakaryocyte progenitor cells. So Polycythemia rubra VERA, not only the RBCs are high in number, but there are also high in number of the WBCs and even the platelets counts. If you go with the Philadelphia chromosome in these patients, the Philadelphia chromosome is negative in Polycythemia rubra VERA. However, more than 95% of the patient will have genus kinase, which is called as JAK2 mutation positive. So rubra VERA, this JAK2 mutation is positive. It's one of the very important tests to diagnose the Polycythemia rubra VERA. What is genus kinase? Is basically a cytoplasmic tyrosine kinase that transfuse signals to the hematopoietic rod cells like erythropoietin to normal cells and neoplastic cells with increased production of all the cell lines. So you can see in this slide, large number of cells of RBCs are there. They increase production of the erythroid series predominantly. Talking about the clinical feature of the patients with Polycythemia rubra VERA, the onset is usually insidious. So it's not the acute presentation, usually the insidious onset, and the patient age is usually above 60 years. Classically, the patient above 60 years presenting to you with tiredness, itching and vertigo, you can consider this patient may be a case of Polycythemia rubra VERA. Especially on examination, if any patient having itching, vertigo and hepatosplenomegaly, always consider it may be a case of Polycythemia rubra VERA and advise the patient to have the CBC test. And in CBC you see the hematocrits and RBC count. However, in some cases, headache and the visual disturbance because of the increased hyperviscosity, it can lead to the decreased flow in the brain and patient may have visual disturbance and the headache. Sometimes patient may present with complication of the disease. The complication of the polycythemia may be because of the thrombosis or hemorrhage. Severe itching is common after hot bath. Any patient above 60 presenting to you with itching after common hot bath, then it may be a case of polycythemia. Or sometimes patient may have itching when the patient is in warm environment like heating area or gently heating room. If the patient complains of itching, you can also think of Polycythemia rubra VERA. Gout may be another presentation due to high cell turnover because of the increased turnover of the RBC cells. There may be more production of the uric acid. So gout may be the presentation. Thrombosis and hemorrhage are two major complications of the Polycythemia rubra VERA. अगर आप पेशेंट को चेक करेंगे वो किस तरह का नजर आएगा, तो हाउ यू पेशेंट लुक लाइक, यूजुअली द पेशेंट इज यूजुअली प्लीथोरिक, रेडिश होगा एंड patient may have deep dusky cyanosis of the peripheries and sometimes hands and feet. So there may be injection of the conjunctiva with the redness. 70% of the patient may have splenomegaly that distinguish polycythemia rubra from the secondary polycythemia. In secondary polycythemia, there is no usually splenomegaly, but in case of polycythemia, splenomegaly may be there. Even liver may be enlarged in 40 to 50% of the cases. Dear students, you can see the redness of the face of the patients with the injection of the conjunctiva. This is one of the classical case of 70-year-old male having polycythemia rubra vera. Dear students, the patient with polycythemia may have hepatosplenomegaly. Almost 40 to 50% of the patients may have hepatomegaly and 70% of the patients may have splenomegaly. So this is one of the very important signs of polycythemia rubra vera. Dear students, you can clearly compare the normal hand with the reddish hand with some dusky cyanosis of the peripheral fingers. Similarly, you can see the redness and deep dusky color of the peripheral fingers and the feet. Similarly, in this slide, the deep dusky colors in these slides. So these are the patients having polycythemia rubra vera. Dear student, another patient of 40-year-old male with polycythemia rubra vera is having HB is 19 with injection of the conjunctiva due to polycythemia. How we diagnose polycythemia rubra vera? Dear students, JAK2 mutation screening is one of the routine tests in the screening of the polycythemia rubra vera. Any patient having above 18.5 HB should be screened for JAK2 mutation for any evidence of the polycythemia. However, the final diagnosis is usually made on the bone marrow examination, which shows prominent erythroid proliferations. However, there is a WHO criteria for the diagnosis of the polycythemia rubra vera we will be discussing in the coming slides. Serum ferritin is useful to detect iron deficiency in patients with polycythemia rubra vera because RBCs are rapidly growing, so serum ferritin is usually may be normal or may be markedly low. Uric acid may be raised as we have already discussed. Raised P12 and B12 binding protein may also be seen in patients with polycythemia vera. Dear students, this is very important slide. WHO criteria for the diagnosis of the polycythemia rubra vera. Some major criteria is HB. If the HB in male is more than 18.5 and in female more than 16.5, and second is presence of the JAK2 mutations. The minor criteria: bone marrow biopsy, serum erythropoietin below normal, endogenous erythroid colony formation. These are the minor criteria. So for the diagnostics purpose of the polycythemia, two major and one minor diagnostic criteria can be applied if for the diagnosis of the polycythemia rubra vera, and one major with two minor diagnostic criteria can also be applied. WHO criteria for the polycythemia rubra vera we have already discussed. These are the criteria. So management of the patient with polycythemia rubra vera is aimed at to maintain the normal blood count and fracture volume below 45% and platelet count below 4,000. So patient having PCB below 45% and platelet count below 4,000. To prevent the complications, we have to give some of the drugs which decrease the complication of the thrombosis and hemorrhage. There are three types of the specific treatment. The first one is the venesection. So you can go with the removal of the 400 to 500 of the blood weekly to relieve the symptoms, to decrease the viscosity of the patient as well. Often as a sole treatment with aim to maintain PCV below 0.5 liter per liter is one of the important finding for the venesection. So with venisections, the main aim is PCV below 45. Later, infrequent venesection may be required due to iron deficiency in these patients. So venesection is one of the very sole treatment. If the patient is going well, then only the venesection may be enough. Similarly, chemotherapy, continuous and intermittent treatment with hydroxyurea can also be done. It is used in home patients who do not tolerate or poorly control feature of the disease like thrombocytosis, thrombosis and symptomatic splenomegaly. So this can be used in these patients. Interferon alpha is also very effective in some of the cases. Low dose aspirin 75 mg is routinely used in the absence of the contraindication to prevent the thrombosis. And Greelite inhibitors, which are the decrease in megakaryocyte proliferation, is also used for the treatment of the thrombocytosis to decrease the thrombosis. So these are the few therapies: venesection, hydroxyurea, low dose aspirin and N-Greelite inhibitors. General measures like radioactive P3 in age above 70 can also be used. For hyperuricemia, we give the allopurinols and we advise the patient के उसने hot bath नहीं लेने ताकि उसकी itching का problem ना है. Sometimes बहुत ज़्यादा distress pruritus हो तो H2 blocker भी दे सकते हैं. Dear students, polycythemia rubra vera may develop into myelofibrosis in 30% of the cases. So polycythemia का case myelofibrosis में भी change हो सकता है. Similarly, acute myeloblastic leukemia, इसमें 5% of the cases में acute myeloblastic leukemia भी हो सकता है. So with the students, this and the one of the first slide of the polycythemia rubra vera.